Hello, my name is Brittany Pressler, a nurse practitioner student at South University. I have my patient here. I'm going to start by washing my hands, introducing myself to the patient. Can you tell me your name?
Jason Pressler,
And what's your birthday?
11/25/84,
And can you tell me the year?
2019.
And who's the president?
Donald Trump.
Okay, so our patient is alert and oriented. He is well groomed, well kempt. No obvious signs of distress. I'm going to start out by assessing the skin. I see no obvious deformities, no abrasions, no lesions. Then I'm going to start with the scalp by palpating. Any tenderness when I palpate? So hair is evenly distributed. It is fine. No lacerations, no lesions. Then I'm going to start, head is normocephalic. Hair is evenly distributed, fine texture. Now I'm going to start with the shape of the face. We are equal and round. No obvious signs of injury. We are also going to palpate the head for tenderness. Any tenderness in the palpate?
No.
Then I'm going to palpate the temporal arteries. Those are 2+. Now I'm going to check the cranial nerve 5 or the trigeminal nerve. I'll ask the patient to clench your teeth together. And I'll check for instability of the temporomandibular joint. Any tenderness when I palpate?
No.
Okay, now I'm going to assess the cranial nerve 7, which is the facial nerve. I'll ask the patient to smile. Okay, no facial droop. Then I'll ask the patient to puff out your cheeks. Very good. Everything's symmetrical. And raise your eyebrows like you're surprised. Very good. All are normal and symmetrical. Now I'm going to touch your face. You tell me if it feels the same on both sides.
Yes. Yes.
Very good. Sensation is intact. So when assessing the eyes, we do not have a Snellen chart at the house, but at the doctor's office we would assess that. My patient here, last time he was at the eye doctor, had 20/20 vision. Do you wear glasses or contacts, sir?
No.
Okay. So to assess the optic nerve, which is cranial nerve 2, that is what we would use the Snellen chart for. Now we're going to assess the peripheral vision. So I'll have you look at me, and don't move your eyes. Tell me when you see my hands moving.
No.
So all of our peripheral vision is intact. Now we will check cranial nerve 3, which is our oculomotor. I will use my ophthalmoscope. So you're just going to look into the light. And I note that our red reflex is intact. Our pupils are equal, round, and reactive at 3 millimeters. When light is in front of the pupils, they go down to 1 millimeter. Now we will assess the cranial nerve 4, which is the trochlear nerve. So you will look at me and follow my finger. So our eyes go together towards the nose, so our trochlear nerve is intact. Now we will assess our cranial nerve 6, which is our abducens. We will use the H method for that. So if you will keep your head the same, follow my finger with only your eyes. Very good. So that is intact. Now we will use I will assess the conjunctiva and sclera. So I will pull down, open your eyes. Conjunctiva is pink, sclera is white, iris is blue. Now we will move on to our ears. So after inspecting both of the ears, I see no obvious signs of deformity or drainage, no redness, no lesions, no swelling. Now I'll use the otoscope to look at the auditory canals. Tympanic membrane is pearly gray. Tympanic membrane, pearly gray. No obvious fluid. No redness in the ear canal. Our light reflex is present at the 4 o'clock position in the right ear and at the 7 o'clock position in the left ear. Okay, sir, now we are going to assess your cranial nerve 8. I'm going to stand behind you and I'm going to whisper words. This is our whisper reflex. I want you to repeat what I'm saying.
1, 2, 3.
And we'll do it with the other side.
1, 2, 3.
Very good. Now we will use our 512 Hertz tuning fork to do the Weber and Wren test. We will start out with the Weber test. And sir, you'll tell me if you hear the sound in one ear more than the other or if it's the same in both ears.
Same.
Okay. Now we'll do the Wren test. So we put the tuning fork at the mastoid process and then in front of the ear canal. Do you hear it more behind your ear or in front?
Same.
Okay, we will check the other ear. And
More
in front?
In front. More.
Okay. All right, so that concludes our ear assessment. We will now check the nose. So our cranial nerve 1 or olfactory nerve will be deferred because we cannot assess the sense of smell at this time. So I'm going to assess the patency of the external nares. So sir, if you will put one finger and block off one of your nostrils and sniff. Very good. Now do the other side. Very good. Now I will use this otoscope also and look up your nose. So if you'll tilt your head up. Very good. Septum is midline, no redness, no drainage, mucous membranes intact. Now I will palpate the sinuses, so we will start with our frontal sinuses. Any tenderness?
No.
Okay. Now our maxillary sinuses. Any tenderness?
No.
No? Very good. Now we'll move on to our nose and throat. I do not have any gloves, but I would at this time put gloves on. And I will inspect the lips for symmetry. Lips are moist, pink, no obvious sign of injury. Now I will have you open up your mouth. Oropharynx is pink, uvula is midline. We will now assess the cranial nerve 9, which is the glossopharyngeal. I will have you say A, E, I, O, U.
A, E, I, O, U.
Patient able to say all of those. We will now assess cranial nerve 10, which is the vagus nerve. So I will have you open your mouth and say I. Uvula remains midline. Now I will have the patient stick his tongue out and move it side to side. Very good. Tongue is symmetrical, mucous membranes pink, no lesions or deformities on the tongue. Upon inspecting the throat, the pharynx, the uvula was midline, no erythema, no exudate, and tonsils are present. Now we will move on to the neck. I will inspect the neck, no obvious signs of deformity. Now I will palpate. Okay, we will do some range of motion. So can you move your neck this way? Very good. This way. Very good. And up. Very good. And down. Any tenderness? Okay. Now I'm going to stand behind you and I'm going to put my finger here. I'm going to touch your thyroid. Very good. And I want you to swallow. Okay. Thyroid is intact. No goiter, no nodules. Now we will move on to the lymph nodes. So we will start with the preauricular, which are in front of the ears. they are not palpable at this time. We will then move on to the occipital, which is at the base of the head, not palpable. Then we'll move to the submental, which is at the jawbone here. Those are good. The submandibular, also at the back of the jaw. Those are not palpable. The tonsillar, right here. And then our anterior cervical is at the front of the neck. Posterior cervical is at the back. And then our supraclavicular. No lymph nodes are palpable at this time. Now we will move on to our shoulders and upper extremities. So we will inspect the shoulders at first. So our clavicles and shoulders are intact. Can you shrug your shoulders? Very good. So that assesses our cranial nerve 11, which is our spinal accessory muscle. We will now check the lymph nodes. So we will check the axillary, and our subacromial, central, lateral, subscapular. All those are negative. We will now move on to assess our sternoclavicular. So we will palpate. No deformities. We will move to the acromioclavicular. Any tenderness when I touch?
No.
Very good. And our subscapular. Any tenderness to palpation? Okay, we will now do some range of motion exercises. So with this arm, I want you to raise up and out, down, and behind. Very good. Now with this arm, we will go up, down, and behind. Any tenderness? No. Now we will assess the brachial and radial pulses. Brachial pulse is strong 2+. Radial pulse present, strong 2+. Brachial pulse strong 2+. Radial pulse strong 2+ bilateral. Okay, now we will assess the strength in your upper extremities. If you will squeeze my fingers. Very good. Now hold your arms out straight. Don't let me push down. No, don't let me push up. Very good. So our strength is intact in our bilateral upper extremities. We will now move on to our anterior chest and neck. So upon examination of our chest and neck, everything is symmetrical. Our AP diameter is symmetrical. We will palpate the chest for any abnormalities or tenderness. Any tenderness when I palpate? Very good. Now we will palpate the carotid arteries. Carotid arteries are 2+ bilateral. We will now auscultate the carotid arteries with the bell of the stethoscope. No bruise heard, no thrill felt. We will now move on to assessing our heart sounds. So we will start with the aortic. We'll now move to our pulmonic. Now our tricuspid. And our mitral. Our point of maximal impulse is heard at the midclavicular line in the 5th intercostal space. So we will listen. We hear S1, S2, no friction rub, no murmur heard, normal rate and rhythm. We will now move on to auscultate the lungs. Sir, if you will, every time I move the stethoscope, if you will take a deep breath in and out. Lungs are clear to auscultation bilaterally on the anterior chest. We will defer the breast exam, but patient reports when he does wash his body, no lumps or masses are felt. We will now move on to the posterior chest. So I will assess for tactile fremitus first. So I will put my palms here and ask the patient to say 99. So every time I press in a different spot, he'll say 99.
99. 99. 99. 99. 99.
Very good. Now I will percuss down the back. So if you will take a deep breath and hold it. And breathe out. And another deep breath and hold it. Okay, and out. One more, deep breath and hold it. Okay, now we will assess for bronchophony. So I will have the patient say 99 while I listen. You'll say 99.
99.
Very good. No areas of consolidation noted. I will now check for egophony. So I will now listen while the patient says E.
E.
And again.
E.
Yeah.
E.
Yeah.
E.
All right. No areas of consolidation noted. I will now move on to auscultate the posterior lungs. So when I move the stethoscope, deep breath. Very good. Okay, I will now have the patient lay back and we will inspect the abdomen. Is that okay there? Raise your head up. There we go. Okay, so we will start out by raising the shirt up, inspecting the abdomen. So we have no obvious lesions, deformities, hernias, palpable masses. We will now move on to auscultate the bowel sounds. Normoactive bowel sounds in all quadrants. We will now assess the vascular structure, so assess the abdominal aorta. And that is audible. We will now percuss the abdomen in all four quadrants. So over the liver, we noted dullness, which is normal. We will now move on to assess, we'll palpate all four quadrants using light and deep palpation. Light palpation first. Any tenderness when I touch?
No.
Okay, we will now do deep palpation. So no hepatomegaly or felt over the right upper quadrant where the liver is located, and no splenomegaly located in the left upper quadrant. We will now assess for rebound tenderness. So I'm going to press down hard, sir, and you tell me if you feel pain in the other side.
No.
Perfect. All right, so we will now assess the psoas sign. So this is where we will raise the right leg. Well, raise the right leg. Oh, I'm sorry. Raise the right leg. And any pressure noted? Any tenderness in the abdomen when I press down?
No.
Very good. We will now assess the obturator sign. So I will have you bend your knee. You might actually scoot back just a little bit. So I'll have you bend your knee. And I will place your knee and the hip. We'll move your foot out. Any pain or tenderness in your abdomen?
No.
Very good. Okay, so we will now, you can put your leg down. We'll now palpate and assess the bladder. Bladder is non-distended. I will now have you, while you're laying down, actually I'm going to check your femoral pulses. Those are 2+ bilateral. I'll now have them raised back up. And we will check for CVA tenderness at the costovertebral angle. So I'm going to put my palm on your hand, and I'm going to touch and tell me if you have tenderness in your back. No. Very good. Our rectal and our prostate exam are deferred. We will now move on to our lower extremities. So, sir, if you will, I'll have you lay on back. Okay, so at first we are going to inspect the hips. So we have no instability, no history of previous injury. Now we will assess our range of motion. So I will, if you let me raise your leg up and down and out and in. Very good. We'll do the same thing with this one. Up and down and out and in. Very good. So now we will also check the knee for the same thing. So we'll bend this leg up. And I will palpate the knee for any instability. Patella is in place. And we will go out and in and bend back. Very good. Now we'll do the same thing with the right leg. Palpate the patella, no instability. So we will go down and up and out and in. Okay, we will now assess the anterior drawer maneuver. So what I'll have to do is have the patient bend his leg with the foot flat on the bed. I'll put my fingers here and we will pull out. Okay, we'll do the same thing with the left leg. Bend your leg. Find the hamstring. Very good. Anterior drawer sign is negative, so no ACL injury on either leg. We will now move on down to the foot and ankles. Upon palpation and inspection, no evidence of any edema, no scrapes, bruises, bleeding, deformities, anything like that. So we will check the pulses. So we'll start, we already checked the femoral, which was 2+ bilaterally, so we'll check the popliteal. 2+ bilaterally. Then we'll move down to the posterior tibial. 2+ bilateral. And the dorsalis pedis. 2+. And then we'll do the same thing on the other side. So popliteal. Posterior tibial. And dorsalis pedis, which is 2+. Now we will do range of motion on the ankles. So I will have the patient lift up and we'll go around. Very good. Same thing over here. Lift up and go around. All right. So if you will push on my hands like you're driving a car. Very good. And pull back, pull your feet up towards you. Very good. Good strength in both bilateral lower extremities. So now we will check our sensation. I'm going to feel both sides. Tell me if it feels the same or different.
Yes, same.
Same?
Same.
Very good. Okay. I will now have you sit up. And we will check our deep tendon reflexes. So we will start out by checking the bicep reflex. What I'll have the patient do is we're going to flex the muscle. Flex the muscle. We will feel the tendon where the bicep is. Okay. Now I'm going to have you straighten your arm back out. And we will assess the reflex. We see the bicep tendon move. Same thing here, flex. Okay. Very good. So our bicep reflex is intact, 2+. We'll now check the tricep. Okay, 2+. Okay, we will now check our brachioradialis. So we will have the patient bend their arm. And we see the brachioradialis tendon move. We will check this side. So bend your arm. Very good. That is 2+. We will now move on to the patellar. So I'll have the patient dangle his foot. Okay, 2+. And we'll now check the right. And those are 2+ as well. We will now move on to our Achilles. So I'll have the patient rest his foot in my hand in a relaxed position. And that is 2+. As the foot is making a motion to go down. Very good. So we will now check our plantar response by moving the sharp object from the heel to the foot. You'll lay back for me. And that reflex is positive. We do not have a positive Babinski reflex. Okay, you'll have to stand that down. Okay, we will now check stereognosis, and I will ask the patient to close his eyes, hold his hand out, and I will put objects in his hand for him to tell me if he recognizes those. All right, if you will close your eyes, hold one hand out. Can you tell me what object by feeling? Very good. Keep your eyes closed. Very good. Last one.
Key.
Very good. Okay, so keep your eyes closed. Put that hand down. Now we'll try it with the other hand.
Hand.
Very good.
Key.
Very good. Last one.
Nail.
All right. So our neuro is intact. We will now check the ataxia of the upper extremities. So if you'll open your eyes, take your pointer finger, touch my finger, and touch your nose. Again. One more time. Okay? And do the same thing with the other hand. With your pointer finger, touch my finger, touch your nose. Very good. Neuro is intact. So now I will have him lay back once more, and we will check the lower extremity. So what I'm going to have you do is take your heel, bend your leg to your knee, and slide your heel down your leg 3 times. And again, and one more time. Very good. Now, we're going to do the same thing with the right leg. So heel to toe. Very good. Okay. Now stand or sit. All right, if you will, hold your arms out, palms up. Close your eyes, and I want you to hold those up for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. So our pronator drift, he did not drift in those 10 seconds. We will now stand up and assess our hip range of motion. I'll have you stand over here. All right, if you will bend down as much as you can and touch your toes. And back up. And can you go from side to side? Okay. We will now do the Romberg test. So I will have the patient with his eyes closed, stand with his feet together, hands by his side. No swaying noted. We will now do this with the eyes closed. No swaying noted. So this is a negative Romberg test. The last thing we will do is check the gait and do a little walking test. So his gait is steady, no swaying while moving. So now if you will stand back there and do heel to toe. Walk heel to toe towards me. Okay, turn around and go back. Very good. So I thank you for watching me do my exam. Thank you to my participant. And that concludes our physical assessment. I will now wash my hands, and this concludes our exam.